So I was asked to give a talk on the current status of PSMA diagnostic. I hope I will have a little bit of time to say some words about the future status and how I see the future as well. I was also asked to talk about gallium-68 PSMA-11 in particular, but I see it more as a broad range of PSMA class agents rather than just one tracer or another. I'll start with the disclosures just to be systematic, and now let's get in. I highlight here in red the PSMA and PET-CT imaging, and I didn't highlight gallium-68 and 11 because just to be sure we're all on the same page, PSMA PET agent, they are small peptides inhibitors. They more or less have all the same binding motifs that you can see here. They go to the PSMA target. PSMA is a very relevant target for prostate cancer because it is highly overexpressed at high level by most of the prostate cancer cells. And on that, the development in the past 2 decades, you have many potential tracers using PET imaging radionuclides such as F18, gallium-68, copper-64, and they are all PSMA PET. They basically perform all pretty good. You can see these images here with this very nice tumor-to-background ratio, black on white, very low background. You see in yellow here the primary tumor. You see in blue this pelvic lymph node very easily, and in red some bone metastases. This patient was negative by conventional imaging initially. And so there are multiple potential PET tracers in that space, and of course gallium-68 and PSMA-11 is the one that is where there is the most data on PubMed. It's the one that is approved here at UCLA and UCSF, but there are many others. PYL is just been approved. There are other players. Just that to be sure we're on the same page, they all perform well, and they are all PSMA PET. So I will not focus my talk only on gallium-68 PSMA-11. What I say for PSMA-11 is valid for the others as well. So, brief overview of the current status of PSMA PET. Now, you're probably all aware it has been approved last year, December 2020, for use at UCSF and UCLA. I highlight here the exact label wording that we were able to be granted by the FDA. We're pretty satisfied on the choice of the words. So it is approved for PET imaging of PSMA positive lesions in men with prostate cancer, either with suspected metastasis and who are candidates for initial definitive therapy, so basically primary staging of usually high-risk patients. But it leaves some room for interpretation because with suspected metastasis, it doesn't say specifically NCCN high risk or something, so it gives some flexibility. And similarly, it also approved for patients with suspected recurrence based on elevated PSA. And again, it doesn't say biochemical recurrence, where the diagnostic is made just on the blood. It can be a little bit any type of recurrence because we didn't put that here. So just to put that on the table. And then just recently, PYL was approved, so that's good because it will make it much more widely available to patients outside of just UCLA and UCSF. And the label that that they got is exactly the same. Let's look a little bit at the data that was submitted to the FDA that led to the approval of gallium-68 PSMA-11. We used 2 pivotal studies for that, one in the recurrent setting, one in the primary staging setting. I will briefly go over the main key results here. Let's look at the biochemical recurrence first. We had a bicentric study, prospective phase 2 trial of diagnostic efficacy, 635 patients. The median PSA in this recurrent population was 2.1. And you can see here on the right side, the overall detection rate was 75%. And when you broke it down by PSA level, you can see that the detection rate correlates very well with the PSA level that reflects basically the volume of the disease. And you have under 0.5, 38% of detection rate, up to above 5, almost 100% of detection rate. And we were able to follow these patients. That's what really the FDA required, to have some validation of what you see on the scan in this recurrent population. And in more than 200 patients, we had a validation method, either by PSA change, histopathology, other imaging modality, and with that, then you can give positive predictive value, which is very high in the 90% range. So when you see something on the scan, it is very likely prostate cancer. And with that, this was the basis for the FDA approval. When you compare that to what has been submitted by Lenteus and Progenics for PYL, well, you can see that the detection rates, they are very similar and goes in the same way, starting from 36% below 0.5 up to almost 100% above 5. So again, it goes in the same way to say these are PSMA PETs. It doesn't really matter if it's PYL or PSMA 11. Let's look at the primary staging now. This was also a bicentric study, UCLA, UCSF. The final diagnostic efficacy cohort where we were able to compare pathology to PSMA PET findings consisted of 277 patients who underwent radical prostatectomy and pelvic lymph node dissection. What you can see is that to get these 277, we needed 764 patients to get the scan, because at UCLA and UCSF, many physicians were already acting on the finding of the scan at that time. And you can see that usually PSMA PET tends to upstage patients. And so patients initially scheduled to get surgery finally did not. In a significant number of cases, they can get radiation therapy or systemic therapy or other types of management. And you can see that to get 277 after a scan and surgery, well, we needed 700 patients. So only 1/3 actually underwent surgery. So that's one of the key points. And the FDA was able to recognize that maybe the main strength of PSMA PET is actually not the true diagnostic efficacy parameters sensitivity, was maybe there to select patients to go to surgery or not. So in these 277 patients, 75 were positive on pathology. And on these, PSMA PET was positive in only 30 of them, which turns out to be a sensitivity of 40%. Specificity, again, very high, 95%. And PPV, 75%, and negative predictive value, 81%. When you compare that to the OSPREY trial, the PYL, again, very similar results with this sensitivity in the 40% range, specificity in the 95% range, and similar PPV and NPV. So what does it mean, this 40% of sensitivity? So PSMA PET can really detect very tiny lymph nodes. I show here some images. You can see here pelvic rectal lymph node, a left supraclavicular lymph node of only maybe 1 millimeter. But you can see the signal is very high. It's a clear cut. This is a MET when you see the signal like that. It's just that in these tiny lymph nodes, you have all the cells expressing very high level the PSMA expression at a very high density. But you cannot go beyond the resolution of PET. And this very famous graph, this was for FDG, it was more 10 years ago, more for lymphoma. You can see that under 10 to the 7 cells, the PET scan cannot detect the signal because it's too small. So for PSMA PET, you can translate that not exactly per cell, because it's more a PSMA density that you're imaging. So it's a level of expression, target expression, but at the end, you cannot go beyond the resolution of PET. If the micrometastatic deposit is too small, you may not see it. Here is a study that shows that up to 5 millimeters of tumor deposits, you basically detect 90% of them. But when it goes to 2 millimeters, you missed half of them. And when you compare that, there is always a level of underestimation of the disease with PET. That's normal. You see that if you compare with choline, for example, this is the blue line here, you underestimate more the lymph node disease than with PET. But still, PSMA PET is the best, but it's still not perfect. You cannot go beyond the intrinsic limitation of the PET resolution, basically. To go in the same way with the potential limitations, let's talk about pitfalls. Like any imaging modality, although it's very specific, you have some potential pitfalls. Nothing is perfect. One of which that we may encounter a lot in the clinical practice is the ribs. Like with any other nuclear medicine tracer, basically you can have some non-specific tracer uptake in the rib when you have some trauma. You have some hyperemia, some inflammation, some bone remodeling, and you would have some tracer going there, not because of PSMA expression, just because of some inflammation going on. And this can be tricky in some time when you know that ribs is also a very common site of prostate cancer metastasis, and it can change a lot the management from M0 to M1 in some cases. Especially when the uptake is faint, and you will have these indeterminate findings on the reports, and you don't really know what to do with that because it changed a lot. I put here on the table this nice little single-center retrospective study. They look at 5,000 scans. They identified 60 scans with a PSMA PET solitary rib lesion at initial staging in a treatment-naive population. They follow them for a median time of 36 months with PSA, with follow-up imaging, and with biopsy. And you can see that in these, only one turned out to be malignant. So these lesions were very faint. You can see the SUV is like in the range of 3, so which is low. But it really means that if you have only one lesion, solitary like that, that is indeterminate, you cannot exclude patients from a potentially curative locally treatment. So of course, sometimes the uptake is clear. It is a clear cut. You have very focal uptake, high SUV, and it can happen that it's a solitary MET that happens also as well. But when it's faint and you don't really know, you usually have to discard these findings and consider the patient for curative treatment. So there is always a room for interpretation, and depending on the PET-CT readers, the report might differ a little bit, and you will have to learn how to interpret what is described on the report, depending also on the readers. For example, the lymph node, it can be tricky. Here I show like some small nodes with faint uptake in it, and so this can be nothing, just small inflammation in some lymph nodes, non-specific. But it can also be some early stage micrometastasis in a lymph node. They would basically look the same. And some would call it suspicious for metastasis, on the report. Some would just discard it. And at the end, sometimes it's false positive, sometimes it's false negative. So it can be tricky. I think here we deal also with a more general paradigm between the difference of the treating clinician and the imaging doctor who is doing the report. The clinician, he will act based on the report, and he needs specificity to be sure that what is described is actually disease. But when you read 30 scans a day and you're the PET-CT report, well, you just do systematically, you have to describe everything, and you don't want to miss a lesion, and you have to do things specifically, systematically like that. So this is just part of medical art. Of course, at the end, what really matters is probably the clinician perspective. But one way to sort this out is usually to communicate directly with between the urologist and the PET-CT report doctor. It usually helps out a lot, putting this case on tumor boards as well. But I think this will happen. It will never go away for any medical technique, even in 100 years from now. There will always be some discrepancies like that. We just have to acknowledge it and be aware of it. One other limitation is in the prostate fossa. The PSMA tracers are excreted through the urine, so you have a lot of radioactivity in the bladder when you do the imaging at 1 hour after injection. So it can hide a little bit a local recurrence. You can see here on MRI the tissue recurrence here that is kind of hidden in the bladder activity, similarly here. So it can be a pitfall. Although these images are a bit misleading, in the reality, we don't read the PET-CT with a fixed SUV threshold like that. You adapt your SUV scaling based on the surrounding background activity of the region you're looking at. So if in the bladder you have high activity, where you play with the intensity of the threshold, for example, I put here a maximum of 37, and in that case, you see that even in the bladder, you can see that this tissue recurrence here can be seen on the PSMA PET scan when you play with the intensity. Another way to sort this out is to do a late pelvic bed acquisition. That's what we do at UCLA. It's often very helpful for all the pelvic indeterminate findings. After the first acquisition, at 60 minutes after the injection, patient get out of the scanner, go to the restroom, void the bladder, and then get again on the scanner. We do a pelvic bed acquisition there, and usually it allows to get a little bit of PSMA uptake kinetics The uptake can go up, can go down, and this helps a little bit to sort out. You can see here the bladder SUV decreased after voiding, which allows a better visual definition of this focal uptake in this left local recurrence. So this is always very helpful. Okay, so now if I go forward with the current status, now that I presented the main diagnostic accuracy parameters, now that I presented the main pitfalls, if you compare that to other imaging modality, for distance staging, well, it's pretty clear it is the most sensitive and specific imaging compared to conventional imaging, compared to choline, compared to flucyclovine. You show already this study where we show that in PSA below 2 at early biochemical recurrence, the PSMA PET-CT was almost twice as sensitive than Aximine. I tell you why, I show here why. It's all about tumor to background ratio when you read PET. And you can see here, this left pelvic lymph node metastasis clearly seen, easy peak on the PSMA PET scan. All 3 readers picked it up. It's also positive here on that Aximine scan. But when you look at the SUV, it is 11 on PSMA and 4 on flucyclovine. So the tumor uptake is higher with PSMA because the PSMA overexpression is higher. And the background activity, flucyclovine is an amino acid transporters, and so it goes wherever you have some protein metabolism, such as in the muscle. You can see here very high background activity in the muscle that kind of hide the left pelvic lymph node metastasis here that was easily picked by PSMA PET because there is no background and high uptake. When you compare to CT and bone scan, this is the pro-PSMA, the Lancet study. You can see here in red, that's PSMA. You can see here in blue, that's conventional imaging, CT and bone scan. So you see it's much more sensitive, and it's also a little bit more specific. So often with sensitive imaging, you tend to upstage patients. In that case, you can see that this bone metastasis was missed by CT and bone scan. Of course, if you look back retrospectively, you can see a little bit of sclerosis on the CT. You can see maybe a little bit of uptake on the bone scan. But their scans were called negative initially. But it can go also the other way around. You can downstage patients. You know, on bone scan, you have a lot of non-specific uptake. It's just bone remodeling. So for example, these 2 rib uptake that were very suspicious. This is the bone SPECT, so still the bone scan. You can see they're here in the ribs. They look very suspicious to me. But on the PSMA PET scan, there was absolutely no signal there. So the patient was downstage to M0. And he finally underwent surgery, and the PSA is still undetectable even without hormonal therapy 3 years after. So these were clearly not metastases. So as a take-home message, PSMA PET-CT should replace the other imaging modalities for N and M distance staging. Let's talk a little bit of local staging and versus MRI. So I think MRI should remain the modality of choice for the local staging because of its high spatial resolution, high tissue contrast resolution. It's just that on PSMA PET, you see also a lot of relevant information. You see maybe a bit more disease. In that study, we show that the volume based on PSMA PET is usually higher than on MRI. So, for example, it is more concordant with the biopsy because you miss less lesions. And there is often an overlap between the two. And there are always lesions that are missed either by MRI or by PSMA PET. So at the end, the combination of the two is probably the best and perform better than either modality alone. With this higher, sometimes, sensitivity, you can see maybe more bilateral lesion, more multifocal lesion. You can upstage the patient to T3B or T3A. That can happen. So we did a study at UCLA with 3 blinded readers. And at the end, there was no real difference between the two. And the key limitation was that the spatial resolution of PET is limited. And the inter-reader reproducibility was also impacted. So long story short, at the end, if you have to choose one, you would choose MRI. If you want to do the best, you do both. But I don't think here PSMA PET can replace MRI. We do with Dr. Marks at UCLA a nice concept now. It's to do PSMA PET guided biopsy, and it works pretty well. I have some cases I can show later on. So that's maybe coming in the future for patients that are very high risk. You know they have prostate cancer. For some reason, you have only biopsy that come back negative because you cannot find the right spot or the MRI is difficult. And in these patients, we manage now around like 10 or 15 patients like that where PSMA PET really help us to get the diagnostic of prostate cancer. So as a take-home message for the local staging, I think PSMA PET can be used as a complement to MRI for the intraprostatic tumor detection and staging. I think I reached the limit to my time, so I thank you very much for your attention.